Welcome to this presentation on preoxygenation and apneic oxygenation strategies for intubation. Today, we'll explore how these techniques enhance patient safety during airway management, a critical aspect of anesthesia and critical care. Let's dive into the essentials of optimizing oxygenation to prevent hypoxemia during intubation. Introduction. Preoxygenation is the process of boosting the body's oxygen reserves, mainly in the lungs, before a patient stops breathing during intubation. This is done by replacing nitrogen in the alveoli with oxygen, a process often called denitrogenation. Apneic oxygenation, on the other hand, involves providing oxygen during the apneic period, when a patient isn't breathing, such as during intubation attempts. These techniques are vital because they extend the time we have to secure the airway safely, reducing the risk of hypoxemia, which can lead to severe outcomes like cardiac arrest or brain injury if not managed properly. Physiological basis of preoxygenation. The main objective of preoxygenation is to maximize oxygen stored in the lungs, particularly in the functional residual capacity, or FRC, which is the volume of air left in the lungs after a normal exhale. By having the patient breathe 100% oxygen, we wash out the nitrogen that typically fills the alveoli when breathing room air, a process known as denitrogenation. Our target is to achieve an end-tidal oxygen concentration, or end-tidal O2, of at least 90%, indicating near-complete denitrogenation. This creates a large oxygen reservoir that delays desaturation during apnea, giving clinicians more time to manage the airway. Case example: challenges with preoxygenation. A 60-year-old obese patient with sepsis needs intubation. After 3 minutes of preoxygenation, SpO2 only reaches 92%, and desaturation to 85% occurs within 1 minute of apnea due to high oxygen demand and low FRC. This scenario is an example of how patient-specific factors can undermine preoxygenation efforts. Let's examine what influences its effectiveness. Factors affecting preoxygenation. Several factors influence how effective preoxygenation is. First, the fraction of inspired oxygen, or FiO2, must be 100% to fully replace nitrogen in the alveoli. Anything less slows this process down. Second, airway patency is critical, especially for apneic oxygenation, to ensure oxygen reaches the trachea. Third, the functional residual capacity, or FRC, acts as the oxygen reservoir. A larger FRC takes longer to denitrogenate, but provides more oxygen during apnea. Breathing patterns also matter. Studies show 8 vital capacity breaths over 1 minute can be as effective as 3 minutes of tidal volume breathing. Oxygen consumption, which is higher in conditions like pregnancy or sepsis, speeds up desaturation. Finally, shunt physiology, seen in diseases like pneumonia, ARDS, or atelectasis, reduces oxygenation effectiveness by bypassing oxygenated alveoli. Preoxygenation techniques. There are several techniques for preoxygenation, each suited to different patient needs. The tight-fitting face mask with passive delivery is the standard approach, where patients breathe 100% oxygen for 3 to 5 minutes until end-tidal O2 reaches 90%. This works well for most patients without risk factors. For those with reduced functional residual capacity, FRC, such as obese or pregnant patients, positive pressure techniques like non-invasive ventilation, NIV, or continuous positive airway pressure, CPAP, are ideal. These methods increase FRC and improve oxygenation by opening collapsed airways. High-flow nasal oxygen, or HFNO, delivers heated, humidified oxygen at up to 70 liters per minute and is versatile, supporting both preoxygenation and apneic oxygenation, especially in patients who can't tolerate a tight mask. Preoxygenation for specific patient groups. Choosing the right preoxygenation technique depends on the patient. For those without risk factors for hypoxia, a routine face mask with passive delivery is sufficient and reliable. Patients with reduced FRC, like those with obesity, pregnancy, or abdominal masses, benefit from non-invasive ventilation combined with a head-up position to increase FRC and prolong safe apnea time. For patients with a predicted difficult airway, we combine preoxygenation with apneic oxygenation, preferably using high-flow nasal oxygenation, to buy extra time during airway management. In critically ill patients, especially those already on NIV, we continue it with 100% FiO2 or use positive pressure techniques if they're cooperative, as these patients desaturate quickly and tolerate hypoxia poorly. Case example: apneic oxygenation. Here is a case highlighting use of apneic oxygenation. In the ER, a 30-year-old trauma patient with a cervical spine injury requires intubation. Nasal cannula at 15 liters per minute is used with a face mask, keeping SpO2 above 95% for 4 minutes during a prolonged attempt, ensuring a safe outcome. This emergency case highlights a practical method in action. Let's dive into the various ways apneic oxygenation can be delivered. Apneic oxygenation: when and why? Apneic oxygenation is recommended for patients at high risk of hypoxia during intubation, such as those with obesity, pregnancy, intrinsic lung disease, or a predicted difficult airway. It works by delivering oxygen during the apneic period, maintaining saturation and extending the safe apnea time, crucial when intubation takes longer than expected. However, its benefits vary. It's not equally effective in all patients. For instance, conditions like pulmonary fibrosis or shunt physiology, where blood bypasses oxygenated alveoli, can limit its impact. Despite this, it's a low-risk technique that serves as an extra safety net for vulnerable patients. Techniques for apneic oxygenation. High-flow nasal oxygen is the preferred method for apneic oxygenation, delivering up to 70 liters per minute of heated, humidified oxygen. It's effective because it matches or exceeds peak inspiratory flow, maintaining oxygenation during apnea, and transitions seamlessly from preoxygenation. Standard nasal cannula, running at 5 to 15 liters per minute, is a simpler alternative but less effective due to lower flow rates and lack of humidification, which can dry the airway. Other options like nasal catheters or adapted oropharyngeal airways are less common but can be used, especially in specific scenarios like airway procedures, though high-flow nasal oxygen remains the gold standard for intubation support. Here is a step-by-step example of apneic oxygenation in action. First, remember apneic oxygenation isn't a replacement for preoxygenation. It's an adjunct that extends safe apnea time. It's most effective when paired with a solid preoxygenation strategy to maximize oxygen reserves. Next, keep the nasal cannula utilized with preoxygenation. The standard method uses nasal cannula at 15 liters per minute, often alongside a face mask during preoxygenation. This fills the pharynx with oxygen, acting as a reservoir, even if the mouth is open, as long as the airway remains patent. Always remember to keep the airway patent. Airway patency is non-negotiable. If it's blocked, oxygen can't flow to the lungs. Use a two-handed face mask technique with jaw thrust, or insert nasopharyngeal or oropharyngeal airways to keep it open. Beyond nasal cannula, high-flow nasal oxygen can deliver up to 70 liters per minute, as seen in the Thrive study, though it might interfere with mask seal. Another option is a bag valve mask with a PEEP valve, providing CPAP, around 6 centimeters water, when combined with nasal cannula at 15 liters per minute. In emergencies, like difficult airways or high-risk patients, this technique buys critical time before desaturation. Think obese or critically ill patients where every second matters. So, what does the literature say about this? Apneic oxygenation's benefits are clear. It extends safe apnea time and cuts desaturation risks. The 2017 Oliveira J.E. Silva meta-analysis of over 1,800 patients confirmed higher peri-intubation oxygen levels and fewer hypoxemia events. But there's more evidence to lean on. Diet et al. In 2015 saw no hypoxemia in 31 patients with nasal prongs versus 10 of 60 without. Wimilisena et al.'s 2015 study of 728 intubations showed a desaturation drop from 22.6% to 16.5% after introducing apneic oxygenation. The Thrive study in 2014 kept saturation above 90% for up to 65 minutes with high-flow oxygen. Older RCTs like Ramachandran, 2010, Taha, 2006, and Teller, 1988, also showed prolonged saturation above 95% in various settings. This body of evidence makes a strong case for its use. To sum things up, here's the playbook. Pre-oxygenate with a mask and nasal cannula at 15 liters per minute. Post-induction, keep the cannula running, use a bag valve mask with PEEP if needed, and ensure airway patency. At intubation, remove the mask, but leave the cannula to keep oxygen flowing. Monitoring during preoxygenation and apneic oxygenation. Monitoring is essential to ensure these techniques work effectively. Pulse oximetry, measuring peripheral oxygen saturation, is standard, but can be misleading. A saturation of 100% doesn't confirm full denitrogenation, and it may not rise in patients with shunt despite a good oxygen reservoir. End-tidal oxygen, or ETO2, is the best tool for preoxygenation, with a goal of over 90% to confirm adequate alveolar oxygen levels, though it requires a normal capnogram to be reliable. During apneic oxygenation, transcutaneous carbon dioxide monitoring, or TCCO2, helps track CO2 buildup, especially with high-flow nasal oxygen, where end-tidal CO2 isn't measurable, alerting us to hypercarbia risks. These are a few tools that can be utilized to aid in monitoring if they are available. Complications and mitigation. While preoxygenation and apneic oxygenation are generally safe, there are potential complications. Absorption atelectasis occurs when oxygen replaces nitrogen and is absorbed faster than it's replaced, collapsing alveoli. This can be prevented with positive end expiratory pressure, or PEEP, or recruitment maneuvers after intubation. Gastric insufflation, where air enters the stomach, is a theoretical risk with positive pressure, but rare with high-flow nasal oxygen or CPAP, and no significant aspiration cases are reported. Oxygen toxicity is unlikely due to the short duration of 100% oxygen use. During apneic oxygenation, hypercarbia, CO2 buildup, is a concern, with levels rising 3 millimeters of mercury per minute after the first minute. Monitoring CO2 helps manage this risk. Summary and recommendations. To wrap up, preoxygenation is a must for every patient undergoing intubation to maximize oxygen reserves and prevent hypoxemia. The technique should be tailored to the patient. Routine face mask for low-risk cases, positive pressure for reduced FRC, and combined approaches for difficult airways or critical illness. Apneic oxygenation is a valuable tool for high-risk patients, like those with obesity or lung disease, extending safe apnea time. If able, monitor end-tidal oxygen during preoxygenation and transcutaneous CO2 during apneic oxygenation to ensure effectiveness and safety. These strategies, when applied thoughtfully, significantly enhance patient outcomes during airway management. This slide lists all references used in the presentation, drawn primarily from the up-to-date article, last updated in February 2025, and supplemented by key studies cited within it. These sources provide the evidence base for our discussion, from physiological principles to clinical recommendations. Feel free to refer to these for a deeper dive into the topic. Thanks for listening.